Good afternoon. I'm Dr. Sandra Hernandez, and I'm the President and CEO of the California Healthcare Foundation. For those of you who don't know the foundation, we're an independent, statewide philanthropic organization. We're dedicated to improving the healthcare delivery system for all Californians, with a particular focus on people who are low income. We recognize that in a state as large as California, the marketplaces that people access care are quite different and quite varied. Los Angeles County will look different than the Central Valley or San Diego or the Bay Area. And so we take every 5 years the opportunity to work with local folks, people on the ground, to help understand what the marketplace looks like, what the opportunities are, and what the challenges are. Today, we're focusing on Los Angeles County, where 1 in 4 Californians today live. And in that county, we see a very vast, complex market with hospitals and clinics really varied even within the state. It's an opportunity for all of us to better understand Los Angeles today. And we think it's important in part because to help everybody understand how the market works helps us all figure out what the opportunities might be. Today, we're going to hear from an incredible panel and really just take some highlights from the report that we conducted. One of the things we recognize is that there's a very heavy reliance on the Medi-Cal program in Los Angeles County. And that program has, of course, allowed us to expand coverage on the one hand, and on the other hand, we'll be facing some significant challenges due to HR 1 and all the financial circumstances that are commensurate with that. We also see that in Los Angeles County, there's great variability among hospitals. There are some hospitals that have very strong financials and other hospitals that are serving large, low-income communities for whom their financial situations are quite different. And we'll, of course, hear some of the variations that stand out as public health wins in Los Angeles, things like lower suicide rates and less ER utilization for substance use disorders. So we're looking forward to a really robust conversation today and hearing from our panelists to do that. I'm going to now be turning the program over to Jill Hu-Yigin, who is going to go through the highlights of the report that she conducted. I hope all of you will engage in the conversation. I want to thank our panelists and everybody who participated in the compilation of this report. And so with that, I'm very happy to hand it over to Jill. Thank you, Jill.
Thank you, Sandra. It's great to be here for today's discussion of the healthcare market in Los Angeles. Good afternoon. My name is Jill Gagian. I'm lead author on the Los Angeles Regional Market Report titled Massive Fragmented Healthcare Safety Net Braces for Impact. Here's the agenda for today's event. I will briefly present on the findings of the Los Angeles Regional Report. We'll then move into a panel discussion with regional experts with an opportunity for audience Q&A before we close. We're so pleased to have a fantastic panel today. Dr. Christina Galley is Director of the Los Angeles Department of Health Services. Jim Manta is President and CEO of St. John's Community Health. Santiago Munoz is Chief Strategy Officer for UCLA Health. And Martha Santana Chan is CEO of LA Care Health Plan. Christoph Stremikis from CHCF will serve as moderator. Next. The Los Angeles Regional Report is part of a larger effort, as Sandra mentioned, to understand the organization, financing, and delivery of healthcare in regional markets within California, both at a moment in time and over time. Los Angeles is the 5th report in the series to be released during this round 5, following the San Joaquin Valley, Shasta and Lassen in the rural north, the Bay Area, and the Inland Empire. The San Diego Regional Report is scheduled for November release, with Sacramento region wrapping up the series in December. I want to acknowledge the California Healthcare Foundation's support for this work and the partnership of their fantastic staff. I also want to acknowledge the terrific team I have an opportunity to work with listed on the slide. Next. Before we dive in, I want to take a moment to provide some detail about the information sources used in the report. Quantitative data for the many tables that you will see in the full report, some of which are excerpted in today's slides, come from an array of sources. Chief among them is the Department of Healthcare Access and Information, which we relied upon for data on hospitals, primary care clinics, workforce, and population prevalence for chronic conditions. The qualitative data generated by interviews with regional leaders is critical to the regional reports. In Los Angeles, interviews were conducted with 31 regional leaders across sectors. Notably, the regional interviews were conducted between October and December last year, concurrent with major shifts in the federal and state coverage policy, including federal HR 1, reduced availability of federal subsidies through Covered California, and state cutbacks on eligibility for people with unsatisfactory immigration status. Next. Los Angeles is home to about 10 million people, about 1/4 of the state's population. The population declined by 2.8% between 2019 and 2024, quite a bit more than the state overall, which declined by 0.2%. The bar graph compares the population of Los Angeles in blue to the population of the state of California in green. Compared to California overall, residents of Los Angeles have higher poverty and unemployment and are less likely to afford the median home. The population is a bit younger than the state overall, and a larger share of Los Angeles residents were born outside the US. A much larger share of the residents are Latino and a much smaller share are white compared to California as a whole. Next. Let's turn to coverage. Los Angeles has a higher share of residents covered by Medi-Cal and a lower share covered by commercial sources compared to the state. And the uninsured rate is slightly higher than for the state as a whole. Next. Los Angeles is divided into 8 service planning areas shown in the map on the right of the slide. For the purpose of illustration, 2 of them are shown in the table, spots 5 and 6. Spot 5, West, is a coastal region that includes Beverly Hills and Santa Monica. Spot 6, South, is inland and includes Compton and Watts. The first 2 columns in the table compare some key indicators for the 2 spots. Residents of Spot 6 are about 3 times more likely to be living in a household with income below the federal poverty level as those in Spot 5, and about twice as likely to have diabetes. The key takeaway is that Los Angeles is enormous and incredibly diverse. Next. Los Angeles County operates under the 2-plan Medi-Cal managed care model, with LA Care as the local initiative plan and HealthNet as the commercial plan. Both LA Care and HealthNet delegate a large share of enrollment to other health plans, passing on health plan functions and financial risk. Kaiser was previously one of LA Care's health plan delegates, but now has a separate contract with the Department of Healthcare Services. Molina's enrollment has grown substantially from around 80,000 at the time of the last report to over 500,000. HealthNet and Molina now split enrollment, which is part of the resolution of a procurement dispute. Risk-based provider payment arrangements are a major feature of the market. Healthcare LA IPA is a nonprofit network of community health centers with around 730,000 members, over 90% of whom have Medi-Cal coverage. Multiple provider organizations accept full risk for Medi-Cal managed care populations, including LA Health Services, Ultimate Health Network, Astrana, and Heritage Provider Network. Next. The table on this slide shows the 4 largest health systems in Los Angeles. There's a longer list available in the region. Those 4 systems accounted for 39% of discharges in 2023 in the relatively fragmented Los Angeles market, compared to 73% in the much more concentrated Bay Area market. Only 2 systems accounted for more than 10% of acute hospital discharges in the county. Kaiser with 11%, and Cedars-Sinai with 12%. There's wide variation in the extent to which health systems are serving Medi-Cal members. At Kaiser and Cedars-Sinai, 10% and 13% of discharges are covered by Medi-Cal. At Providence, it's 24%, and at LA Health Services, it's about two-thirds. As shown in the net income margin column, there is wide variation in the financial health of hospitals. Kaiser and Cedars-Sinai are at 5% and 8%, while Providence is at minus 12%. Figures are not comparable for LA Health Services because of the complexity of them. During the interviews with hospital and health system leaders, I heard concerns from many about rising costs and slower revenue growth or even declines as HR1 takes effect. One interview participant said, before we could sustain ourselves, now we're forced to pick apart which programs are sustainable and which are not. Next. Los Angeles has long been a major center for the capitated delegated model of physician services. In this model, physician organizations accept financial risk and clinical responsibility for a population of health plan members. There are almost 100 risk-bearing organizations operating in Los Angeles County, many of them small, but some very large. Historically, large physician organizations in Los Angeles have operated independently, but increasingly they are owned by health systems or other corporate entities such as Optum Health. Two recent examples are Astrana's acquisition of Prospect Medical Group and the Altea's acquisition of Family Care Specialists. I heard very different views during the interviews regarding whether independent practice in Los Angeles is fading or holding strong, but most agree that some level of scale is needed. Next. Community health centers provided 7 million patient encounters in 2023. The four largest community health center systems are shown on this slide. Collectively, they provided 2 million patient encounters in 2023. They provide a wide range of services, core medical and pharmacy services, plus behavioral health and dental. They also play a major role in street medicine and supportive health. Community health centers in Los Angeles rely heavily on Medi-Cal, often receiving 90% or more of net patient revenue from the program. That's currently a major concern due to reductions in state-funded expansion of Medi-Cal for all Californians regardless of immigration status, and expected reductions in Medi-Cal coverage due to HR1's provisions. A community coalition led by community health centers and organized labor proposed a 5-year half-cent sales tax that narrowly passed on the June ballot in Los Angeles County and is projected to raise $1 billion. Next. County government plays a critical role in the safety net with responsibility for physical health, mental health, and substance use treatment divided across 3 departments. LA Health Services operates an integrated delivery system of hospitals and clinics serving Medi-Cal and uninsured patients. With a budget of $6.5 billion annually, LA Health Services provided almost 3 million patient visits in 2025 and has full risk contracts with multiple Medi-Cal managed care plans covering about 350,000 members. The Department of Mental Health runs the County Mental Health Plan, providing specialty mental health services. With a budget of $1.4 billion, DMH serves around 250,000 people annually. The Bureau of Substance Abuse Prevention and Control within the Department of Public Health provides a continuum of specialty substance use disorder services. With a budget of $760 million annually, SAPC serves around 35,000 patients. These 3 branches operate with enormous scale and complexity to serve millions of Angelinos. Next. Let's turn to workforce. In Los Angeles, physician supply is similar to statewide supply, which does not mean it's adequate. The bottom half of the table on the right shows that, considering physicians working at least 20 hours a week, Los Angeles has about 95% of the primary care physicians available statewide, about 111% of the specialists, and about 105% of the psychiatrists. LA Care has made major investments in workforce development over the last several years, including programs for recruitment, loan repayment, residency, and other training programs and scholarships. Community health centers are involved in a wide range of workforce efforts, and two new medical schools have opened since the last regional report 5 years ago, Kaiser and Drew. In spite of positive developments, there are ongoing concerns about access, especially specialist access, and especially for men. As one interviewee noted, independent practices are joining the UCLAs and Providences of the world and don't take Medi-Cal. Next. In the CalAIM program, Enhanced Care Management provides resources for care coordination and care management for patients with complex needs. In 2024, about 1.1% of Medi-Cal members received ECM services in Los Angeles compared to about 1.5% statewide. Community support services go beyond traditional Medi-Cal healthcare services, adding services for health-related social needs. In 2024, just under 1% of Medi-Cal members in Los Angeles received community support services, about half the rate of 1.9% statewide. One interviewee respondent called CalAIM labor-intensive but worth it, but interviewees also noted the challenging billing and reporting requirements. Next, let's turn to behavioral. Los Angeles has an acute shortage of community-based beds for those needing behavioral health services. The lack of beds creates a bottleneck in the system. Hospitals can't discharge patients who no longer need inpatient services but aren't ready to go home. The BCHIP program was intended to address the shortage of behavioral health infrastructure options, and the May 2025 round of funding resulted in just over $1 billion for Los Angeles County. But it will take years for all that new investment to translate into available beds for patient use. Next. Turning to important issues to track going forward, in the interest of time, I will just highlight two of them. How will Los Angeles County respond to the expected increase in uninsured Angelenos? And how will California's response to state budget shortfalls in HR 1 impact that response? And how will the robust community health center sector fare as expected Medi-Cal coverage losses and restrictions on payment for those with unsatisfactory immigration status take effect? With that, I will turn it over to Christoph to moderate the panel.
Jill, thank you so much. My name is Christoph Stremikis. I'm the Director of Market Analysis and Insight at the California Healthcare Foundation. I want to begin with a huge thank you to Jill. That was really heroic, as I think all of you understand now, if you didn't before. This is an incredibly complicated healthcare market down in Los Angeles, and I would say the report that she has put together is incredibly helpful at untangling some of that complexity and explaining a lot of the programs. What I'd like to do now is invite our panelists. I'm really excited. I was really excited to hear from Jill, and I'm really excited to hear from our panelists. We have four leaders down in LA to help us untangle a little bit more of that complexity and help us really understand from their perspective what major challenges and opportunities are presenting themselves in the market right now. And so each of our panelists, I'd invite you to turn your camera on and unmute yourself. And while they're doing that, I'll just remind our audience, we have a fair bit of time. We've got about 30 minutes or so to engage in a conversation here. There's a lot of questions that have already come into the Q&A box. As you have them, please put them in and we'll get to just as many as we can over the rest of the hour. But let's go ahead and get started. What I might ask to kick us off is, each panelist, could you just remind us your name and where you work? And then could you share from your perspective within your organization, what is one key operational challenge that you're facing? What is it and how are you dealing with it?
So good afternoon, everybody. My name is Martha Santana Chin. I'm the CEO here at LA Care Health Plan. I've been in this role for about a year and a half. And, the question is actually quite a challenging question because there isn't a single operational challenge, but I'll tell you what we're really focused on and what's really keeping us up at night right now. And that is one of our key priorities is protecting access to care and keeping as many people covered as we possibly can. And doing that while we're trying to ensure our own long-term financial sustainability and the same for our safety net provider community. As you know, we are focused on serving low-income communities here in LA County, and our safety net network is a critical part of our ability to be able to do that. So as we're looking at our own needs internally and the needs of our members, we're also very mindful of everything that's hitting the provider community. We are entering an unprecedented period of pressure, state budget cuts, HR1. For us as a health plan, and I'm sure for many of our audience members, mounting audits, oversight, just the action just keeps coming. And all of this is converging at the exact moment when our enrollment is projected to decline sharply. For us here at LA Care, that means that by 2028, we're expecting that we're going to lose over 650,000 members. That's 650,000 individuals that will no longer have coverage. That's a 30% reduction for us. It's not small. That's the equivalent of an entire US city losing coverage. And that's not just an enrollment challenge. It's really fewer people being covered means fewer resources flowing into the healthcare system, means more strain on our providers, our hospitals, our clinics. And by the way, they're already struggling with workforce shortages, rising costs, growing demand, et cetera, et cetera. So for us, our focus is very clear in terms of what we're doing about it. We're really doing everything we possibly can to streamline and strengthen our own operations to make sure that we are resilient and long-term sustainable. We are partnering with our providers to make sure we're doing everything we can to safeguard access in the safety net and the providers that are here to serve our communities, and doubling down on everything we can possibly do to keep as many people covered as we possibly can. More specifically, there are 3 key areas that we're partnering on with our provider organizations, and that is strengthening primary care and post-acute care, reducing avoidable emergency department usage, and reducing administrative barriers, including advancing interoperability and data exchange capability. But quite frankly, these efficiencies are simply not going to be enough. Preserving access is going to require bold state partnership, sustainable financing, and policies that are going to reinforce a safety net at this time when we have extraordinary stress. So, we're very clear-eyed about what's ahead of us. People and organizations are going to get hurt, and what we need to do in the meantime is to do everything we possibly can to minimize harm and act together and do it with discipline, with urgency, and shared purpose. And I just got to tell you, I'm really proud that in LA County, we have partners and leaders across the healthcare industry and in office, community-based organizations, et cetera, that are up to that challenge and very much leaning in to partner with us in that space.
Thank you so much for that, Martha. There is a lot of threads there that I'd love to dig in on in just a second, but I want to get other folks in here. Maybe we'll go to Santiago and then try Christine again. But Santiago, can you just remind folks your name, your organization, and then what is one key operational challenge that your
organization? Thank you. Good afternoon. I'm Santiago Munoz. I'm the Chief Strategy Officer at UCLA Health. I'm delighted to be here, and I'd love to address that question. Let me start by thanking the Foundation for recognizing the importance of market analytics. I believe it's so important in a competitive market, particularly in our fragmented market, as Jill has described, not only to focus on the market trends, but also the implications for consumer access, and also appreciate Jill and her team and their willingness to take this on and with such expertise, commitment, and professionalism. So at UCLA Health, in addition to providing clinical care, we seek to educate and train the physician workforce that cares for Californians. The university's mission of education, research, and service is carried out in part through this clinical enterprise. The UCLA graduates and trainees at many levels are so essential to caring for all Californians, both within our health system and as trainees, and when they depart and practice in their communities. But among the many challenges, that we face, is that we're dealing with every day on an operational level is access to behavioral health care, and at all levels of behavioral health care, in an effort to better serve our patients and provide a more comprehensive set of services. We're in the process of opening a new state-of-the-art psychiatric hospital in the mid-Wilshire area of Los Angeles. Here, it should be open by January 27, to address the the access crisis that we're witnessing and we're living through. It's been a project that's been in the queue since about 2021, and we purchased a closed hospital building, which commenced a lengthy and complex effort to open a new hospital, a 128-bed state-of-the-art hospital by early 27. So obviously searching for the most cost-effective approach, notwithstanding a very significant capital commitment, but being as thoughtful and as responsible with limited resources, given the many funding challenges that we're living through and that are coming our way, as has already been described. We purchased that building, which included a medical office building and a parking garage, with the intention of creating a new integrated behavioral health campus, anchored obviously by a new inpatient psychiatric facility, but that would provide community behavioral access at all levels. The new hospital will be a state-of-the-art plant, but also allows us to utilize existing hospital space in West LA for additional adult medical and surgical services. So this helps us address another pressing challenge, right, which is access to surgical care in general. So we'll be relocating the current inpatient psychiatric care from the Westwood campus to the larger behavioral health campus at Mid-Wilshire, and allowing us to expand adult and tertiary, quaternary medical surgical services, and with the intention there of reducing the wait times in the queue for surgical services at every level of the community. So we've been working really hard to try to find cost-effective and responsible solutions to the access issues that we're living through and having to address, and wanted to highlight that as an example.
Thank you for sharing that. Look forward to jumping into that one too. Let's go to Dr. Galley. Dr. Christina Galley, can you remind folks kind of where you work, and then what is one pressing operational challenge?
Thank you for having us, and it's really a pleasure to be here. There are so many things going on. It's quite a busy time, as Jill outlined in the summary. The biggest operational challenge for us is how we're going to achieve fiscal sustainability over the near term. And I think the biggest problem, as I look at California and Los Angeles and what's going on, is the low base rates for Medicaid. For those who aren't familiar with Medicaid financing, Medicaid is paid through a combination of base rates and supplemental payments. It's an incredibly ornate scheme of financing that can occupy one for years to gain interest in. But I think when we look at what's really threatening the viability of the safety net and especially the hospital system, it's those low payment rates. And that's why HR 1 is so damaging. And that's why some of the state budget cuts are so damaging, especially with respect to HR 1, because it threatens the supplemental payments that all of us have come to rely on to make ends meet. And that's just not a sustainable outcome for any of us. That's combined with the fact that hospital care is incredibly expensive, and we're all really faced with dramatically rising costs because of the regulatory environment for hospital-based care in general in California and Los Angeles. It's incredibly onerous from a regulatory environment. More and more laws and more costs are passed on to hospitals every year. So when those base payment rates don't keep up with the cost of care, it's really just not sustainable. So much of what I know all of us are doing and what many hospitals are struggling with is really, how do you try to cope with that? How do you deal with more patients who are sick coming in through the ER? How do you deal with more and more patients who are going to lose their insurance as a result of HR 1 and other measures, who are not going to have regular sites of care and access to care? And then how do we try to keep the doors open to continue to serve them well?
Thank you. Those are some big challenges. So let's get Jim in here, and then let's circle back on some of them. But Jim, could you remind yourself or remind our audience your name, the organization that you work at, and then what is one really pressing operational challenge from your perspective?
Jim Manja, President and CEO, St. John's Community Health. And I think there are so many challenges, as Martha and Christina have pointed out. But I think for community health centers, the major challenge are the administrative burdens and the loss of coverage for the Medi-Cal population. So the federal cuts through HR 1 are going to cut about 15% of our patients from Medi-Cal. And if the state cuts go through on UIS, on the undocumented, which have been postponed for a year, that will be another 30% of our patients that will lose coverage. So we're talking about a serious distress. The safety net is under siege. And we're talking about millions and millions of Californians losing their health coverage. I think the move of undocumented folks from managed care to fee-for-service means they will not have access to specialty care, since specialists will not take Medi-Cal rates. The IPA that we're part of, Healthcare LA IPA, pays Medicare plus for specialists and for the specialty network. And also all of those patients, for us, about 8,000 patients will lose eligibility for CalAIM. So they will not have the enhanced case management and community supports that are so critical for patients with acute and chronic diseases. So I think there's, basically the safety net is under siege, and I've never seen anything like this in my 25 years here. And I think we're in for a rough ride for the next few years.
Thank you for sharing that, Jim. I maybe want to dig into that a little bit with the whole panel. So maybe I'll go to you, Martha, if you're willing. Could you just remind people at a very high level, some of these we've heard sort of what HR1 is going to do, but can you remind people about like the changes in redetermination and the new community engagement requirements? What are those things? Just very quickly, what are those things? And then I'd like to ask the whole panel, what is your organization doing to try to mitigate sort of these responses? What can you do within your organization? What are you trying to do? Martha, is that fair? Can you just kind of give us a very high level?
Yeah. Happy to do that. So at a very high level, more frequent renewals, right, for the population, that's one. And then the second is work requirements, community engagement requirements for the adult population, expansion population. And, one thing that I'll just add there is for those of you that have not necessarily been tracking, originally HR1 required that there'd be medical exemptions for a segment of the population if they were disabled or had complex chronic conditions or substance use disorder or some mental health, behavioral health issues, and several other categories of exemptions for medical frailty. Since then, CMS has released an interim final rule that also layers on an additional requirement of ensuring that people can prove that they are unable to work even if they have those conditions. And, they call it, significant impairment. They've got to be able to demonstrate that there's significant impairment such that they would not be able to work. So if you could just imagine someone with cancer is not only going to have to demonstrate that they have the diagnosis, but they're also going to have the evidence that they cannot work. And this is going to be devastating for many of our communities. I know the state has taken action to try and stop that, and coalition with other states, they've taken legal action. We'll see whether or not some of that action, those legal actions take hold by the end of the year. But this could be very, very devastating. And so one of the things that we are the most focused on is this idea that we've got to do everything that we possibly can to keep LA covered. And so we have launched a countywide effort to help people keep their coverage, especially given all of the changes that are coming our way. That is going to make for a very confusing time for individuals that are the working poor, who have, in some cases, literacy issues, digital literacy, and limited reading ability or limited ability to be flexible and go out and get support to get paperwork and things of that nature handled. So what we've done is we've launched a countywide effort to keep people covered. And it's included in a $35 million investment to support our communities. And we're essentially helping people navigate the new eligibility rules, work requirements, and also navigate what's happening here at the state level with all the changes that are impacting different segments of the population. Jim mentioned earlier that there are changes that are impacting individuals that have unsatisfactory immigration status. And so, for example, next year, there is an intention to start charging premiums for that segment of the population. And people are going to need help. They're going to need help navigating. So our programming and the investments are going to be going towards county-wide outreach and enrollment support. We've launched a coordinated outreach effort across the county that it includes social media, digital communication, traditional media, community-based messaging. And in the coming weeks, you're going to see a new website, Keep LA Covered, that is going to make available new materials, make people aware of events that are happening in the community so that we can mobilize the public to help support friends and neighbors keep their coverage. And we're partnering with very, very closely with the Department of Social Services here in the county, with the Department of Healthcare Services, with clinics, hospitals, community-based organizations, community health workers, and the list goes on. Part of what we've also done is launched a program that we call Coverage Champions. And so far, we've trained over 100 of our own members who have signed up to volunteer, to pound the pavement in their community, to make sure that family, friends, neighbors know how to keep their coverage. We've also trained 400 of our own employees to do the same thing in their community, volunteer. Our 14 community resource centers are staffed to actively support renewal and enrollment. And we're continuing to expand that through partnerships with nonprofits and other faith-based groups and community-based organizations. The other thing that we're investing some resources into is technology. And that includes tools to expand text messaging, data sharing capabilities, enhanced digital support to make sure people know when they're due, get reminders to submit the paperwork necessary, and keep things as simple as possible for the communities that we're serving. And along with that, we're investing in having organizations support our communities, get education to help them with digital literacy and just navigate the process here. So there's quite a bit of investment. One other thing that I'll share that I'm excited about is we are partnering with the county and a number of local agencies to stand up workfare programs so that people can qualify for community engagement volunteer opportunities through organizations that the federal government is recognizing as able to deem someone completing work requirements, and so, or community engagement volunteer opportunities. So we're very excited about this effort. We think it's an all hands on deck moment, and we're trying to do everything that we can to make sure that we keep things aligned and simple and partnering with our local trusted organizations.
It really does seem like an all hands on deck moment, and maybe sort of in that spirit, I'm wondering, Jim, if you could you speak specifically about the role of clinics in trying to mitigate some of these coverage losses, responding to more frequent redeterminations? Like, what is your organization doing, and what additional support would be useful?
Well, I think what St. John's did in partnership with other community health centers, with unions, with private doctors, with hospitals, was to pass Measure ER. And Measure ER raises the sales tax by half a penny, and it brings in $1 billion a year for 5 years. Provides a significant amount of dollars to LA Health Services to help it plugs part of their deficit. It creates a coverage program for everyone who loses Medi-Cal, either because of immigration status or because of work requirements or renewals. So we're going to see a lot of people falling in and out of Medi-Cal. So for the period in which they fall out, they will have a coverage program that will continue to be able to provide a significant amount of the services they received under Medi-Cal. We're also funding, there's also $50 million a year in funding to replace all of the federal grants for HIV care, Black maternal health, equity funding that were cut by the federal government. So a lot of those grant programs will be refunded through the County Department of Public Health through Measure ER funding. So I think, that was our big effort. And I think the goal of part of the goal of creating all of this activity around Measure ER and its passage is to create a Medi-Cal voter, to create a voter who actually votes for the safety net, that understands the role that it plays in their lives, and that holds politicians accountable around these kinds of programs, Medi-Cal in particular. So how is it that a Democratic governor and a Democratic dominated legislature, 2/3, could actually institute the cuts to Medi-Cal that we're looking at, that Martha referenced, and, we're all looking at for next year? I think we need a constituency that's going to be able to fight back. And that's a long-term effort and a long-term goal for Measure ER.
Yeah. Thank you for that. We've got a lot of questions that are coming in from the audience around work requirements and redeterminations, and there's one theme here around the use of AI. And so I don't know, Dr. Galley, maybe you can speak to this. If not, we'll sort of go to the broader panel. But do you see a role, for AI in helping address these, work requirements or redeterminations? Are there some administrative efficiencies that can be captured in some way? Are you aware of that happening in the county? Is there a role for AI?
Thanks for the question. It seems there's a role in AI in many things. So I would like to think yes. In the County of Los Angeles, the Department of Public and Social Services has the lead role in Medi-Cal eligibility and determination. And I can't speak directly to whether or not they're considering using AI in that process. I will say, despite, I think, the promise of AI and many of the ways in which I think AI will be helpful broadly, so much of the challenge of these community engagement requirements and the every 6-month eligibility determination and some of the other roles is how just individually onerous it is on the patient, the member, to have to fill out paperwork, sign paperwork, bring in documentation, attest to different things, document the validity of different things on a very, very frequent basis. And a lot of those processes are still unclear. There isn't yet full guidance on how all of these processes will work out, despite the fact that many of them go into effect on January 1st, 2027. But it's not yet clear how entities and providers in the state of California, much less Los Angeles County, will actually need to go through the work of fulfilling those requirements. Even just for community engagement requirements in California and in the nation, that guidance just came out. There's a lot of details to work through. It's an immense amount of work to stand up that program in the short timeline that was given. And individual patients and members are going to have to think about what they have that they do that might be able to fulfill that requirement. The medical frailty exemptions that Martha spoke briefly about are really complicated as well. And as written, that final rule puts a lot of that responsibility onto practicing physicians to attest that an individual is not able to work. I will say, as a physician, that's not what we're trained to do. That's not our expertise. We're not occupational health experts, the vast majority of us. And so it creates, I think, a real stressor on the system. And I don't know how AI would really come into that. I'm sure there's a lot of brilliant people out there who have ideas about how AI will do that. But whatever it is, it's going to take time. And time is the one thing right now that we don't have.
Yeah, thank you for that. Santiago, I'm going to give you the last word sort of on HR because there are so many questions here that are coming in. Our last word on HR1. You sort of mentioned, and Dr. Galley also mentioned the significant financial or federal funding cuts that are also attendant to this law, many of which directly impact hospitals, though certainly impact the entire safety net delivery system. Can you help our audience understand, like, just how serious, is this for UCLA? Like, what can you share? And if not about UCLA, just generally, like, what is the magnitude of this cut? And what is the response in terms of, potential operational changes that are required because of it? Does that question make sense? And can you?
Well, it absolutely does. No, I appreciate that. I mean, it's extremely serious. For the university wide, we're talking about hundreds and hundreds of millions of dollars over the next years. I will say, I mean, it strikes me that kind of a recurring theme here in response to the report and reflecting on the report is expanding the work and activities from our traditional portfolios of looking at our role in the competitive market, very characteristic of CalAIM, right? Trying to reach beyond what we've normally done to create kind of community-wide solutions. And as a historically a very traditional academic health center, we've invested, very heavily in primary and ambulatory care, to improve access and keep people out of very costly academic hospitals. And so we are equally vulnerable with these cuts coming our way in terms of access and coverage and HR1, and beyond kind of becoming having a larger umbrella and working together with different segments of the industry. We have to be more aggressive about what we have historically done, right? I mean, we've been more aggressive about keeping people out of the emergency room, standing up, more urgent care, more immediate care, and then just being in a business that we haven't historically been in, investing very heavily in, home health, LTAC, SNF, acute rehab, being in a position of being able to influence that downstream and moving patients as quickly as possible and as safely as possible into an appropriate lower cost community setting, rather than staying in a more costly hospital setting. So I think key theme here is, we're all talking about doing things that, traditionally may have not been in any particular space, but that we have to work together on and do more of. So, to answer your question, I think, the provisions of HR1 and what's coming our way are very significant, on what has historically been, an institution must cover not only the cost of clinical care, but, the cost of the teaching expenses and everything that we're doing for the community.
Thank you for raising CalAIM, and that's another. We've got a lot of questions that are coming in from the audience on CalAIM, and so I do want to go there now, and I think you all probably have some important perspective on this. But maybe I'll start with you, Martha, if you're willing. Can you just remind, Jill gave us a quick overview of community supports and enhanced care management, but just a really quick reminder of, CalAIM, what it is, and then can you also, from your perspective, share where have you seen real success when it comes to delivering CalAIM, offering CalAIM services in LA County?
Sure. Thank you for the question. So CalAIM is a very bold initiative that the state of California undertook several years ago with the idea that if we treat people and their needs holistically, social, behavioral, and physical health, we're more likely to help them stabilize and live a healthy life longer term. And as part of the CalAIM effort, there were a couple of new features in the Medi-Cal program that plans were able to make available. The first is something that we call enhanced care management. And enhanced care management is essentially care management services provided to very specific high needs populations, most likely in person or preferably in person, and highly encouraged to be in person in the community by organizations and providers, community health workers, social workers, nurses that ideally have some level of lived experience or direct experience with the population that they're going to be serving. So these are, people that have behavioral health conditions, experiencing homelessness, justice involved, foster youth, maternal health individuals, and several populations like that. And that enhanced care management program is essentially a very intensive care management program that's community-based, that's intended to make sure that not only are we supporting individuals with navigating the healthcare delivery system effectively, but making sure that they're being connected with the right services and the right care at the right time. For us at LA Care, at this point, we've had somewhere between 30 and 40,000 individuals at one point or another enrolled in that program. And we have seen dramatic improvements in utilization as a result. We've seen significant double-digit drops in emergency department utilization, unnecessary inpatient utilization, a higher rate of connection with primary care physicians, and several other benefits. People really like that program. We've had several, of our own members testify in our own board meetings about how their favorite new person is their enhanced care management and provider. So enhanced care management is one feature that's made a significant impact. And then there's community supports, and community supports are essentially intended to provide services that are targeted to help make sure that you avoid costly institutional care, ED utilization, inpatient utilization. So a couple of examples are housing, tenancy and navigation support services, medically tailored meals, and recuperative care are just a few, just to give you a few examples. And what I would say, just generally speaking about the community support services, is that some of them have definitely made an impact, but we've had to revise criteria over time to make sure those services are targeted to the individuals that really are going to benefit. There are other services that really haven't necessarily made the kind of impact that we were hoping for. And one example is on the housing navigation services. The fundamental problem that we have in the county of Los Angeles is that we don't have places where people can live, temporary, permanent, supportive, or affordable. And so if you're trying to help people navigate to somewhere and you can never get them placed, then there's not a big return on that service. And unfortunately, the other thing that HR1 has done is it's not only impacting the healthcare for low-income communities, it's also impacting access to housing vouchers, nutrition assistance, and the list goes on and on. So CalAIM has done some very, very important and good work and laid the tracks for what we need to do to support whole person care. And by the way, it built on programs and pilots of the past. It wasn't, a de novo. The state piloted and then, built on it. Unfortunately, right now, because of where we are, the promise of CalAIM is not what it used to be. So hopefully I answered your question and gave the audience a bit of an overview of where we've been and where we are.
That is super helpful, and we are starting to run a little bit short on time, but I do want to bring in the other panelists here. And so, Jim, maybe a question for you both, right now, what do you see, where have you really seen the impact of CalAIM? And where do you think it needs to go? Like if you're sort of looking forward a little bit, given some of these federal headwinds, the future is uncertain, but where do you think additional services might be useful?
Well, I think what's so disturbing about the situation with CalAIM is that we have a program that's successful, to Martha's point, and now we're talking about cutting it back. So, in California, by moving all of the UIS population out of managed care and into fee-for-service, they will all lose their access to CalAIM. And so we're going to see an increase in emergency room use. We're going to see an increase, less use of primary care. People will be sicker, hospitalized more, et cetera. So I think what we need to do is stabilize that program. And I do think we need to expand it, again, assuming that there's buy-in from the state and that we have the funding. But the question is, there are populations who have not yet benefited from the CalAIM program that could. And so I think if I had a vision and I was making those decisions, I would expand it out to more vulnerable populations and increase the care management for patients with with significant chronic disease and other conditions which are not currently in there. But I do think we're under a situation now where we're looking at rollback, not expansion.
Yeah. Dr. Gallia, maybe in a minute or two, maybe same question for you if you have perspective. Like, where have you really seen an impact in CalAIM, and where would you like that program to go?
Sure, thanks. For me, the most exciting part of the CalAIM is the one that just in Los Angeles County launched on July 1st, which is the CalAIM Justice Initiative. It was the latest to roll out for a variety of reasons, but I think it has a lot of promise for helping to break the cycle that we see in some of our justice-involved populations, where they tend to cycle in and out of jail and then have trouble with accessing stable healthcare after they're released to the community. And as most people probably know, the majority of individuals who end up spending time in the LA County jail system are there for a quite short time, and then they're released back to the community, but they lose their Medi-Cal coverage while they're in jail, and they lose their connection to resources. They often don't have a way of accessing care efficiently once they are released. They don't necessarily have a stable supply of release meds or appointments. And that stretches across both the physical health realm as well as the behavioral health realm. And a large number of these individuals have co-occurring substance use disorder and need services from the drug medical system, or have co-occurring behavioral health disorders and need care from the specialty mental health system. And the CalAIM Justice Initiative provides pre-enrollment or enrollment into Medi-Cal and coverage for 90 days pre-release, as well as a variety of services that help enable their warm handoff to providers within the community. And I think it can really go a long way to helping transition a very vulnerable population to effective sources of care that ultimately can impact health outcomes. Now, getting an appointment doesn't mean that their healthcare quality indicators improve. It's necessary but not sufficient to improve healthcare. But I think that we'll see when we look at actual quality indicators, just as we have within various populations when we've looked, that when you actually provide that stable care and high quality primary care and outpatient services, you can have improved outcomes on diabetes, hypertension, other chronic diseases, tobacco screening and tobacco cessation, depression screening and connection to counseling where needed, and a variety of other really critical health measures.
Thank you for that. Santiago, we're going to give you the last word. Unfortunately, we're running short on time, but maybe in 30 seconds, where have you really seen the biggest impact when it comes to CalAIM, and where would you like to see that program?
Yeah, in the community, it's been for us, the ECM provisions, the enhanced care management provisions, in, addressing the needs of high needs and, really complex clinical profile patients. So, it curtailing that and not optimizing, what has been built is I'd agree with kind of the theme that raised here, that's tragic. And, the need to redouble that investment rather than curtail, particularly for this population that is a high utilizers, and stay in costly hospitals is something that could continue to prove beneficial if we were to make that investment.
Thank you. I could talk to you guys all afternoon. There's so many, and I think our audience could ask you questions all afternoon too, but unfortunately we're at time. Maybe ask for just three things before we close. First, I want to remind sort of the audience and everyone that this is the fifth in a series of 7 reports. Our next event actually is taking place in San Diego in person on November 10th. Information on that is available on our website. We'd certainly love to see all of you there in person in November. Second, there will be an evaluation of this webinar that will pop up on your screen after you close the window. Please do take the time to fill that out. We absolutely will review all of those and use that to inform future programming. And finally, I welcome Jill back to the screen. Please join me in sort of a virtual round of applause and thank you to our panelists and Jill, everyone behind the scenes at Golden State Health Policy and at the California Healthcare Foundation that helped put this event on. Really appreciate everyone's work and time being here. Thank you so much. And with that, we'll adjourn.